Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. We are moving on with the top 200 drugs. We're already at drug 151. So we'll have 151 to 155 covered today. That first medication is Cefuroxime. Brand name is Ceftin. Remember, there are multiple generations of cephalosporins. Typically with cephalosporins, the earlier the generation, first generation, second generation, the more coverage you have towards specifically gram-positive bacteria, classic examples being Staphylococcus, Streptococcus, and that's true of cefuroxime for the most part. It tends to have much more gram-positive coverage. It is a second-generation cephalosporin. Usages, you might see this medication for strep throat, otitis media, pneumonia. It has activity against Moraxella catarrhalis, more commonly referred to as MCAT, also has H. flu activity, and then strep and staph coverage as well. Typically, it's not going to cover MRSA, or it's not going to be beneficial for that. So that is a potential downside there, where you'd have to look towards an alternative agent that does have that coverage. This medication does have IV NPO availability. I will say this is relatively newer information within the last year or two here of making this podcast. The oral suspension has actually been discontinued by the manufacturer. So keep that in mind that at least currently at the time of this podcast, does not exist, or it's not available. Getting back to mechanism of action, just for completeness sake, this medication binds penicillin binding proteins in the bacterial cell wall, ultimately leads to the inhibition of cell wall formation, and that causes the death of bacteria. That coverage I alluded to already. Again, methicillin-sensitive staphylococci, so not MRSA. So again, that's going to cover some of those common respiratory, upper respiratory, and into the pneumonia type pathogens, Streptococcus, Haemophilus influenzae, Moraxella catarrhalis as well. In addition to Group A, beta hemolytic streptococci, such that cause strep throat. Adverse drug reactions, as you could imagine, it's pretty similar to penicillin antibiotics, other cephalosporins. GI is going to be problematic. Diarrhea probably most predominant with an antibiotic like this. It can cause some nausea, stomach upset as well. And then, of course, we can have some reactions, rash, itching, hives. So important to pay attention to that, document that, making sure that we're able to judge later on what type of reaction that was to that medication. So again, if you have that patient reporting issues with skin reactions, that type of thing, do our best to take good notes, documentation. When did it start? How long did it last? How bad is it? Severity, how much skin did it cover? Is it just a small area, or is it the entire body? Are there other symptoms along with that? So again, determining, getting down that documentation of what exactly happened can help us decide later on if we need to use a medication from this class of medications. Is that risk-benefit assessment appropriate to be able to use another medication that's similar to a medication like cefuroxime? It may accumulate in renal impairment, particularly severe renal impairment, so you may have to do some dose adjustments there depending upon the situation and how aggressive we're trying to be. And then from a drug interaction standpoint, keep in mind that antacids can actually reduce cefuroxime concentrations. So important, particularly in taking that oral dosage formulation. Giving antacids with this medication can reduce concentrations and lead to treatment failure. Warfarin concentrations can actually be increased as well, and that can lead to an elevated INR. Number 152 is Ketoconazole. Brand name is Nizoral. I'm going to focus mostly here on the systemic administration of Ketoconazole. There is topical formulations as well. This is a fungal type medication where it's used to treat fungal infections. It's from that class of azole antifungals, so mechanistically, it inhibits fungal cytochrome P450 dependent enzyme, linosterol 14-alpha demethylase. This is responsible for converting linosterol to ergosterol, which is important in fungal cell wall formation. GI adverse effects are going to be the most common nuisance type adverse effects. Usually most patients can handle this, but obviously if nausea and vomiting and diarrhea are very, very severe or something, we're going to have to reassess that patient and see if there's other alternatives available if they can't take it anymore. Liver failure. This is an important one to remember. I've definitely seen this come up on board exams for sure. Ketoconazole is associated with liver failure. There is a boxed warning on this. Again, higher doses, longer term use, probably more likely to encounter this. As far as the U.S. manufacturer labeling with this, if ALT gets above the upper limit of normal or we're greater than 30% above baseline liver function tests, or if the patient is displaying symptoms of liver toxicity, hepatic impairment, it's recommended to interrupt therapy and then obviously continue to monitor liver function and then make a determination of that risk versus benefit of restarting that medication, looking for an alternative. Obviously, if we've got an easy alternative available to treat that fungal infection, that's not an azole antifungal, that's probably the route we're going to go. If we don't have any other options, obviously we're going to have to do kind of a risk versus benefit assessment. Drug interactions with this medication, lots of them. It inhibits CYP3A4. It can increase concentrations of statin medication, simvastatin kind of being a classic example there. Alprazolam, which is brand name is Xanax. It's a benzodiazepine. Amlodipine, commonly used blood pressure medication. Pixaban, warfarin, commonly used anticoagulants. Many seizure medications. There are some antipsychotics and different psychotropic medications that concentrations may go up as well. So this is very, very important to look at drug interactions with this medication if you are going to use it to treat a fungal infection. Next medication is Pregabalin. Brand name is Lyrica. Primary uses that I see this medication used for are nerve pain type situations, neuropathy, other pain syndromes along that line, fibromyalgia, RLS. Rarely have seen it used for anxiety type symptoms. I have seen it used for menopausal type symptoms, maybe to try to reduce hot flashes. Again, probably much less common. We've got usually other agents that we use for those purposes, but I have seen this medication used for that purpose too. Mechanistically, it binds voltage-gated calcium channels at the alpha-2 delta subunit, which ultimately reduces the outflow and action of excitatory neurotransmitters. Now, if you remember Pregabalin, you can pretty much lump it together with gabapentin as far as the side effect profile goes. Sedation, edema, fatigue, these are all potential adverse effects. It is cleared by the kidney So in our geriatric patients, which I work with frequently, this is a potential issue, that accumulation, where maybe a dose, maybe they're on 100 milligrams twice a day, and that dose has been great. Well, as a patient ages, that drug may accumulate a little bit more, and they may be more susceptible to oversedation and increasing fall risk and things of that nature. The potential advantage, or one of the pharmacokinetic advantages of pregabalin over gabapentin, is this dose-dependent absorption issue that gabapentin has. So you may get more bang for your buck when using pregabalin, particularly at higher dosages, and that's because of a dose-dependent absorption issue with gabapentin. If you want to Google search that, Google search gabapentin dose-dependent absorption, MedEd 101. I've laid it out in a blog post before. Not going to go into the details here, but if you want to check that out, look at more details there, feel free to do that. This is a controlled substance, so there is some risk for potential for withdrawal symptoms when trying to get patients off this medication. Risk of dependence and abuse. Important to note that as well. From a drug interaction standpoint, don't worry too much about CYP enzymes. That type of thing doesn't really affect that much. The biggest thing are probably those additive type drug interactions. So that CNS depressant type activity, alcohol, opioids, benzodiazepines, first generation antihistamines like diphenhydramine, for example, Z drugs, other sleepers like zolpidem, for example. These can all have that additive CNS depressant effect. And, particularly with opioids, we definitely worry about respiratory depression becoming too problematic there. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, MTM, or the NAPLEX exam, go check out meded101.com/store. We've got tons of resources, tons of testimonials. We've helped thousands of pharmacists prepare for and pass their board exam, and we can help you too, certainly. So go check that out, meded101.com/store. Support the sponsor, which directly helps me keep doing this podcast, which I enjoy doing and sharing this education. Next medication is esomeprazole. Brand name is Nexium. Mechanistically, this inhibits hydrogen potassium ATPase in parietal cells, which prevents gastric acid secretion. So this is a proton pump inhibitor, also abbreviated as a PPI, which you will definitely hear in practice for sure. These medications are antacids. They're used for GERD, peptic ulcer disease, things along those lines. It's generally dosed 30 to 60 minutes before a meal for maximal effect. Administering it at bedtime, it may be a little bit less effective. It's not that you can't, but that efficacy may not be maximized if we don't give it 30 to 60 minutes before a meal. With that said, I've had geriatric patients, that maybe they get up and they eat breakfast right away and we don't have that full time period. Medication's still going to be effective. And, if you're treating something symptomatic like GERD, for example, and they say it's relieving their heartburn, they're probably getting adequate concentrations and it's probably okay to continue that. So just kind of a little bit of a side note, like it's not, absolutely 100% has to be within this window. But I typically recommend it if patients can do it because you may get the maximal benefit from it there. Adverse effect profile. So there's some longer term risks with PPIs, and it's really why we want to try to reassess them, at 4 weeks, 8 weeks, and see if patients can now stop them, get off them. And some of those kind of longer term risks are osteoporosis, can lower B12 levels and magnesium. So that's definitely something I've chatted with dietitians about. Good reminder to check out my book on food-drug interactions, very popular on Amazon as well. Lots of good stuff in there about that if you're trending more towards dietitian and diet and drug interactions. Also C. diff risk. That is associated with chronic use of PPIs there as well. As far as, tolerability, short-term adverse effects, occasionally I've maybe seen some diarrhea and stuff, but by and large, in the short term, they're generally pretty well tolerated. Again, treat something like GERD for up to 8 weeks and then reassess, because we want to try to get patients off these medications if we can. Now, there are situations like Barrett's esophagus where it's likely that we're going to need long-term PPI therapy. But again, that's something a clinician's going to take a peek at, kind of reassess that risk versus benefit and what the condition is that we're treating. So again, attempt to maintain lowest effective dose in patients who fail trial discontinuations. Want to try to minimize some of those long-term adverse risks. In my practice, I've seen PPIs get started in the hospital a ton. And then we're kind of unclear on the diagnosis, why it was started, if it was stress ulcer prophylaxis or something else. And then these PPIs just kind of get left on board. And I think it's really, really important, particularly if you're, working with a hospital, working on transitions of care, and then ultimately working in a situation, maybe in assisted living or long-term care, where you're working with these patients, getting that diagnosis and why a PPI was started, super, super important. Finishing up with drug interactions, we do have some interactions via CYP2C19 inhibition with esomeprazole. Citalopram is a good example. I've definitely blogged about that on MedEd 101. If you want to go into more details on that, you should be able to find some stuff there. Same thing with clopidogrel. Again, kind of still controversial how clinically significant this is, but I do think it is important to recognize that. We do have other PPIs in this class, like pantoprazole, for example, that may have less impacts on CYP2C19. So again, might be a situation where we try to convert there. Last medication, number 155, is ipratropium and albuterol combination. When I first graduated, I definitely saw this combination much, much more than I do now. These are two short-acting agents. So ipratropium is a short-acting anticholinergic. Albuterol is a short-acting beta agonist. So mechanistically, the blockade of muscarinic receptors leads to reduced activity of acetylcholine in respiratory smooth muscle, which ultimately leads to that relaxation of the airway. The anticholinergic activity of ipratropium can also help dry up secretions. So if that's a big issue in a patient with COPD and lots of secretions, this anticholinergic type medication may help a little bit with that. Now, typically in COPD, we're using kind of controller medications, long-acting anticholinergic medications, often called long-acting antimuscarinic medications or LAMA therapy. And I would say kind of the short-acting combo use of this medication has definitely fallen out of favor as we've used those controlling medications a little bit more and more. Occasionally, in addition to dry mouth, you may get a little bit of throat irritation with this. Systemic anticholinergic adverse effects, I typically don't worry about too much. The systemic absorption is fairly minimal. With that said, if you've got a patient using a ton of this, they're using it multiple times throughout the day, and maybe in combination with other anticholinergics, we could potentially have some additive type effects there and a high anticholinergic burden, where you can get, worsening of BPH, dry eyes, constipation, maybe even some CNS effects. Again, if you're just using Comavent alone, that ipratropium in there, probably not going to cause a lot of systemic adverse effects. So that's definitely a good thing. Now, the albuterol side of things, mechanistically, it binds and agonizes beta-2 receptors. Remember, beta-2 receptors are on the lungs. You have two lungs. That relaxes that smooth muscle, opens up the airway, and obviously allows for easier breathing. It's going to help this combination is going to help kind of acutely relieve respiratory distress and difficulty breathing. On the beta agonist side, the SABA therapy, short-acting beta agonists, Albuterol can cause some kind of shakiness, tremor, can increase heart rate a little bit potentially if you get high enough dosages, and it rarely may increase some anxiety as well. Again, it's going to kind of depend upon systemic absorption, how much the patient is using. If patients only use it, every so often, it's probably not going to be a big deal. If they're using it multiple times per day, we may run into this a little bit more. Rarely, albuterol can reduce serum potassium, and it may actually be used in some rare situations for hyperkalemia, elevations in potassium. When we're using it for respiratory purposes, typically the dosages we're using aren't going to get high enough to really kind of be clinically significant on that potassium level. But again, in rare cases, if you've got a patient who's taking that inhaler a ton all day long, that could be a potential issue there. Drug interaction standpoint, I don't really worry too much about it. Again, respiratory medication, we're trying to get the more localized effects and hopefully not much systemic absorption. So I don't stress too much about drug interactions, but the two things I'd maybe look out for is kind of some of the additive potential on tachycardia, for example. If you've got other medications, stimulants that increase heart rate, using albuterol in this combination medication may increase that a little bit further. Diuretics can lower potassium levels. Again, if we're using high doses of albuterol, that could have a type of additive effect and drop that potassium further. And then that anticholinergic burden as well. If you've got a patient on, diphenhydramine and a tricyclic antidepressant, and now they're taking a bunch of ipratropium in this combination as well, that could have some additive effect on dry mouth, dry eyes, constipation, and things of that nature. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, found it helpful, do us a huge favor, leave us a rating and review on iTunes or whatever platform you're listening on. Also, go support the sponsor, meded101.com/store. Lots of books, clinical pearls, testing materials there to help you prepare for your board exams. Your support there is greatly appreciated as well. If you want to reach out to me, suggestions, comments, Eric Christensen, PharmD, BCPS, BCGP, you can connect with me on LinkedIn, or you can send me a message there. You can email me at mededucation101@gmail.com as well. Thank you all so much for listening. Take care, and I hope you have a great rest of your day.